Hi, good evening, everyone. Welcome back to one of my favorite webinar. Always very obliging, Dr. Aslani, my friend, an expert in echo, trained in Mayo, and done a lot of papers. So I think without further ado, we don't need any introduction. Aslani, we start with your first case.
All right, so I just share my slides. All right, I hope you all can see my slides. Okay?
Can.
All right, thank you, Dr. Betty, for inviting me again for this very popular webinar series of yours. So just as per usual, we're going to share a few interesting echocardiography cases. Today, I thought that I share a little bit of a transesophageal echocardiogram. So there are two types of echocardiogram mainly. One is transthoracic echocardiogram, where you scan the patient from outside the heart. Another one is what we call a semi-invasive procedure, where you scan the heart from inside the stomach or inside the esophagus, upper part of the gullet. This is because the probe is nearer to the heart, and you can see a certain part of the heart better with a transesophageal echocardiogram. So let's go for our first case. I think this case was in Mayo Clinic. We have a 62-year-old man with methicillin-sensitive Staphylococcus aureus, native mitral valve endocarditis, have some complication, including severe mitral regurgitation and multiple cerebral infarcts. So he have an IVAD. This is an intravenous port for chemotherapy for his T-cell cutaneous lymphoma. So he was transferred from outside hospital. This is in 2014 with mental status changes, hypotension, and sepsis. So just go straight to the mid-esophageal 4-chamber view of this echocardiogram. So this is the left ventricle, right ventricle, left atrium, and right atrium here. So this is basically the home view of the transesophageal echocardiogram. So something interesting that I show you here is that you can see that this is the posterior leaflet of the mitral valve. That's the anterior leaflet of the mitral valve. You can see an abnormal mass here inside the left atrium. In fact, if you go to 60 degree, which is the bicommissural view, so this is the left ventricle, left atrium. So this is the left atrial appendage. For those of you who are interested, this is where 95% of your clot that occur in the atrial fibrillation and stroke come from there. That is the left upper pulmonary vein, and that is what we call the warfarin ridge or the Coumadin ridge, which is the ridge between the left upper pulmonary vein and the left atrial appendage. If you look here in the bicommissural view, so this is the same structure here, and you can see some rounded ring structure there. And some tips to determine which scallop that is involved in mitral valve pathology is that you use your mid-esophageal 4-chamber view to determine whether it is a posterior or anterior leaflet problem. So here you can see that this is posterior and this is anterior. So this is an anterior leaflet problem. And this bicommissural view is to determine which scallops are involved. So this is 1, 2, and 3. So because this is anterior and this is 2, so this is something wrong in the A2 scallops of the mitral valve. So as you can see here from the color view, there are significant severe mitral regurgitation directed to the opposite direction of that mass in the mitral valve. And this is a 3D view of that mitral valve leaflet. So mitral valve got 2 leaflets. We have the anterior and the posterior leaflet. And we can see here at the A2 segment of the mitral valve. So this is the mass. Okay. So what exactly has happened here? So this is what we call a pseudoaneurysm of the mitral valve. So normally we have a pseudoaneurysm of the LV or RV wall or the left ventricular outflow tract. And this is quite interesting because you have a pseudoaneurysm of the anterior mitral valve leaflet because of this infective endocarditis. And the pseudoaneurysm, interestingly, has also perforated into the left atrium, causing a mitral regurgitation that is going across the mitral valve leaflet into the pseudoaneurysm and into the left atrium. And more clearer, if you see here, this is a view from the side. of that mitral valve. That's the anterior mitral valve leaflet, and that's the posterior mitral valve leaflet. And you can see here the pseudoaneurysm, right? That look like a ring here because of the infective endocarditis. So basically, if you see this kind of thing in your valve, it is 99% of the time infective endocarditis until proven otherwise. So the patient, this is basically, I wanted to show a typical example of what is called mycotic or infectious aneurysm of the anterior mitral valve leaflet because of infective endocarditis. I have shown you how to determine the scallop movement using the mid-esophageal four-chamber view and bicommercial view to determine which leaflet is involved in the infective endocarditis process, which is the A2 scallop of the mitral valve. And basically, in this case, sometimes the 2D is not enough, and the 3D view makes us visualize the pseudoaneurysm much better. So the patient successfully underwent a mitral valve replacement, and actually is doing very well. So that is my first case of mycotic aneurysm of the anterior mitral valve leaflet.
Okay, I want to ask you, when your patient have mycotic this embolism, right, causing let's say an abscess elsewhere, and of course the treatment of choice is still the mitral valve replacement, and this patient obviously needs the mitral valve replacement because of the severe mitral regurgitation. But how long do you think that you should start the antibiotic before you submit the patient to subject the patient to a mitral valve replacement?
This is a very interesting and very relevant questions, and a lot of unnecessary delay in the operating of infective endocarditis. So in general rule, easily said and done is a patient that is unstable with refractory heart failure with cardiogenic shock. We don't wait until the antibiotic work, so we go straight away to the operating theater. The problem is, of course, to convince the surgeon to go in, because the problem is when they are too ill, they say that the patient is too ill, so they cannot go in. When the patient is well, they ask to continue antibiotic until the patient is very ill, and then the patient again not good enough to go for surgery. So that is a step that we do not want to get into. So if let's say the patient have what I said is clinical instability, you don't wait for antibiotic, you go straight away. If the patient is stable, the indication to go for early surgery, and we say early surgery is between 10 to 14 days after starting antibiotics, is a big size vegetation, more than 10 millimeter, someone with septic embolus, and someone with severe regurgitant lesion. So all of these are indication to go relatively early, 10 to 14 days of antibiotics.
Okay.
So we'll just go to our second case now. So we have a 56 years old male with history of Hodgkin's lymphoma and radiation 20 years ago, and basically developed severe radiation-induced aortic stenosis. So these cases is just for me to introduce to those who are not aware that a certain treatment that is involved in cancer-related therapy can also have cardiovascular side effect. One of the commonest cardiovascular complication of cancer treatment is radiation-induced valvular heart disease. That usually happen many years after the radiation, and that's why sometimes it's very important to get a history of radiation. And this is very pertinent, especially when we talk about someone with breast cancer, blood malignancy like lymphoma, and also certain type of lung cancer where they have radiotherapy to their chest wall. So I just wanted to show you after this the common pattern of radiation-induced valvular heart disease. There are transthoracic echocardiogram here and also transesophageal echocardiogram. So we had an echo here in 2017. This is a pre-operation. And I just wanted to show you a very typical pattern of calcification in radiation-induced valvular heart disease. So basically, the place that you wanted to concentrate is the area here between the body of the anterior mitral valve leaflet and the root of the aortic. valve. Okay, so this area, so whenever you see a calcification that is continuous from the aortic valve up to the body of the anterior mitral valve leaflet, and a patient with history of radiation, this is radiation-induced valvular heart disease. So this is the pattern that you have to remember. It doesn't necessarily cause stenosis. In fact, most of the time it causes regurgitation more than stenosis. If you look at the picture on the right side, the patient has significant aortic regurgitation and also significant mitral regurgitation here. This is a short axis view of the aortic valve. As you can see, the aortic valve is tri-leaflet, and you can see a calcification of all three of the leaflet. Look at the short axis view. You can see that the mitral valve leaflet, the leaflet tips and the commissure actually opens well. So this is not rheumatic mitral valve disease. This is a apical four-chamber view. So this is a Mayo format, the only hospital in which this is inverted. The LV is on the left side and the RV is on the right side. And you can see, yeah, in Mayo Clinic, the only place, I have no idea why they do it, but it's the only place where for an apical four-chamber for them is the balik.
Okay.
And you can see here calcification of the mitral annulus that can look at first glance like a degenerative mitral annular calcification. This is the continuous wave Doppler at the right parasternal view of the aortic valve. And you can see a significant velocity of 4.1 meter per second and mean gradient of 40.1 millimeter mercury, showing severe aortic stenosis. So this case, I just wanted to show a typical appearance in echocardiogram for radiation-induced valve disease. Oftentimes, because the calcification also involve the aortic root and the aortic annulus, the coronary artery is also diseased. The ostia of the left main and the ostium of the right coronary artery frequently involved, and a lot of these proximal coronary arteries also have stenosis. The calcification affects the body of the anterior mitral valve leaflet and also the aortic valve. History of irradiation more than 10 years is typical. The red flag is breast, lung, and blood malignancy. The patient also have high gradient severe aortic stenosis and aortic regurgitation. I also do this 3D way of very accurately measuring a mitral valve area. This is what we call a multi-planar reconstruction to ensure that we are cutting at the narrowest point of the mitral valve leaflet. So this multi-planar reconstruction shows the mitral valve area of 1.9 centimeters squared. So it is only mild mitral stenosis. So there is no mitral surgery done, only aortic valve replacement.
Okay, before we go, can we go back to the second case? I have a few questions I want to ask. Okay, now you have so much calcification, right?
Yes.
Would that make the surgery even more difficult?
Correct. So the surgery is difficult. The outcome in terms of valvular disease is the worst when we are dealing with radiation-induced valvular disease, because they need to debride the calcium on the mitral valve, especially. The aortic valve is not really a problem because a lot of experience to deal with that. With the mitral valve, because the border between the left atrium and left ventricle can be very fragile, when they debride the calcium at the mitral annulus, they take a risk of a rupture of this junction between the left atrium and left ventricle. So you are right, it's a very risky, high-risk operation, but nonetheless can be done successfully.
Okay, the other question is, now we have a case where the aortic valve is significant, yet the mitral valve is not significant, it's just mild. Okay, would you, let's say this is, let's say a 45 years old gentleman, would you advise to replace both anyway?
So basically, we don't know in terms of how fast it's going to be progressing. Basically, as a rule of thumb, when you're dealing with mixed valvular heart disease, or let's say when you're doing any other heart surgery, any valve disease that is moderate or more, you do during the initial index operation, moderate or more. So if this were to be moderate mitral stenosis, we have had done both of the valve. But because this is only mild mitral stenosis, therefore we didn't do it.
Okay, so you didn't do. I don't know whether looking back later, you wish that you
Yeah,
did.
we might regret
Yeah.
the decision.
Okay, last question I have is that, do you see this type of radiation complication? Okay, do you see constrictive?
Oh yes, I mean, in fact, we see a lot more constrictive pericarditis than radiation-induced valvular heart disease. So definitely we see constrictive pericarditis in this situation. So again, a patient with a history of radiation, if they come with a failure symptoms with say pedal edema, raised jugular venous pressure, Kussmaul sign, ascites, but the echo show preserved ejection fraction with respirophasic septal shift and beat to beat septal shudder. So that is an indication of constrictive pericarditis.
How do you treat that? Huh?
So constrictive pericarditis, if let's say it is radiation induced, the only treatment is pericardiectomy, which is the stripping of the pericardium. Now, if the other constrictive pericarditis, on the other hand, what you can do is to do cardiac MRI and to see whether there is active inflammation of the pericardium. If there is an active inflammation of the pericardium, rather than straight away do a pericardiectomy, you might want to try a 3 months course of non-steroidal anti-inflammatory and also aspirin to see whether you can cure the constrictive pericarditis without needing pericardiectomy. Because you have to remember that pericardiectomy is a very messy operation because oftentimes the pericardium stick very strongly to the heart muscle and the outcome is not very, very good. So it's not a very good outcome operation, but nonetheless, in many, many patients, that is their only option.
Okay. Can I ask you, is there a chance of a restrictive pattern with radiation?
Yes, it's possible, but rare. The restrictive pattern is more commonly seen with chemotherapy-induced cardiomyopathy, in which you have heart failure with a reduced ejection fraction. So this can happen, but rare with radiation-induced cardiomyopathy.
Okay, we can go on to your next case.
So
We
let's
have
look
a
at
question at the end, yeah? Okay.
Let's look at the interesting case number 3. Basically, this is a case where the transthoracic echocardiogram was done on the 30th of June 2022. Surgery was done on the 1st of July 2022, and patient was discharged on the 6th of July 2022. So within the span of 1 week. So look at what we see here. So on the top left, you can see a parasternal long axis view of the heart. And when we look at the left atrium, we can see a mass that is flattering inside the left atrium here.
Oh, yes.
The question in this case is that the mass is attached on the anterior mitral valve leaflet or the posterior mitral valve leaflet. If you look at the color view on the right side, you can see severe mitral regurgitation that is directed posteriorly. As a rule of thumb, whenever you see a primary mitral valve abnormality, the direction of the jet is opposite to the primary pathology. So in this situation, as the mitral regurgitation is directed posteriorly, one would have expected that the mass attached to the anterior rather than posterior mitral valve leaflet. So that's what we think first in this case. Because of the posterior directed MR jet, the mass is attached to the anterior mitral valve leaflet. But when we look closely in the zoom view, then we get a little bit more confused because look like maybe the mass is attached to the posterior mitral valve.
Yes.
But if it's attached to the posterior mitral valve leaflet, why then is the jet directed posteriorly? If you look at the short axis view, so in transthoracic echocardiogram, the short axis view is an excellent view to determine which scallops is involved. So just as an orientation, here is lateral and here is medial. So that is an A1, A2, and A3 scallop. This is P1, P2, and P3 scallop. As you can see here, there's a mass attached to the P3 scallops of the mitral valve leaflet. And again, we can see that this is actually a posterior rather than anterior pathology. So how do we explain the posterior pathology with a posteriorly directed mitral regurgitation? If you look at the apical four-chamber view, you can
So
see that
much.
preserved ejection fraction, but torrential severe mitral regurgitation. The ejection fraction is still preserved at 62.9%. For primary mitral regurgitation, the definition of reduced or depressed ejection fraction is EF that is less than 60%. And the definition of severe left ventricular dysfunction is an ejection fraction that is less than 45%. So very, very different from other illnesses. So this is the way we quantitate the severity of mitral regurgitation. We do something that is called EROA, or effective regurgitant orifice area. So this is the whole of the leakage. And we take a threshold of 0.4 centimeters squared as severe. And you can see this patient have a hole size of 0.75 centimeters squared. We also look at the volume of the blood leaking to the left atrium, and we take the number 60 mils as significant, and the patient has 78.4 mils of leakage of the mitral valve. So this is severe mitral regurgitation, both with eyeball and color, and also with quantitation. So basically, this patient have infective endocarditis with vegetation at the P3 segment of the mitral valve leaflet. Normally, the jet is directed opposite to the direction of the pathology, but in this case, the jet is directed to the same way. So why is this the case? When I will show you at the transesophageal echocardiogram, this is interesting because the vegetation is very large, and this actually caused almost total destruction of the posterior mitral valve leaflet. So it's not just flail, the leaflet during systole go down vertically into the left atrium, causing the jet to be directed to the same direction. So if you look here at transesophageal echocardiogram, so this is what we call a two-chamber view. So A1, A2, A3, and P3. If you look at the way the vegetation go, you can see that the vegetation and the leaflet go vertical. That's why the regurgitation goes straight to that direction rather than to the opposite direction. And finally, with 3D echocardiogram, we can see clearly why the jet is directed posteriorly. So that's the anterior mitral valve leaflet. That is the posterior mitral valve leaflet, and you can see total destruction of the P3 segment of the mitral valve leaflet with vegetation attached to it, causing posteriorly directed mitral regurgitation. Now, even though in this patient, he have big vegetation, surprisingly, they are able to repair and not replace the valve successfully with only trivial mitral regurgitation seen. So this is the mid-esophageal four-chamber view with a trivial mitral regurgitation, and two-chamber view again with trivial mitral regurgitation.
But I thought you said the posterior mitral valve is already torn.
Yes, the P3 scallop was destroyed. They are still P1 and P2 scallop. So the surgeon actually suture the P2 scallop to the medial commissure and somehow able to repair the valve.
And okay, so now the thing is that during the surgery for infective endocarditis, okay, the main aim is not only to treat the MR, but to get rid of the vegetation. Am I not right?
Yeah, you're right.
So how do you get rid of the vegetation so confidently without getting rid of the valve?
Sometimes the surgeon, this is something that is controversial. Sometimes if they can identify the vegetation and they can separate what they think visually as infected material to non-infected material, they can try to repair the valve. So this depends on the confidence and the competency of the surgeon. But like you said, as a general rule, in this kind of situation, normally you replace rather than repair the valve.
Yeah, I mean, looking back, I don't want to go 3 months, 5 months later and say that, oh, the vegetation has not been cleared.
Yep.
Okay, this is very interesting. That
All
you
right.
actually repair the valve.
Yes.
Okay.
We do have a case recently of a doctor that come to IJN, young guy with the vegetation of the tricuspid valve. Also done repair successfully because, as you know, a tricuspid valve replacement is something that is very tedious because of the low pressure system. You replace with a mechanical valve. they tend to develop clot. So actually repaired successfully. I think it has been a year since the repair. So far, so good. So I think it is possible, but need a surgery with a very high skill and competency.
And this the reason behind his infective endocarditis over the right side is because he's a drug user.
We have no idea because he is completely healthy and we do all sort of investigation.
So he
to see
denied
whether-
being a drug user.
Yeah, he's denied being a drug user. He doesn't seem like a drug user. He denied any unsafe sexual practices, and in fact, he doesn't have any indication of retroviral infection.
Okay, we go on.
Right. So we look at the interesting case number 4. So we have a 43 years old female, okay, and this is a parasternal long axis view. What you can see here is that the aortic valve look slightly thickened. The movement look abnormal. The wall of the left ventricle is thickened, and you can see that there are turbulent flow systolic across the aortic valve. Okay. There is a zoom view of the aortic valve. You can see a thickened and calcified aortic valve with restricted opening. We put a color view. We see a little bit of turbulent flow across the aortic valve in systole, but we didn't see any diastolic flow, so there is no regurgitation. And
Is the patient very techy?
110 beats per minute.
Sorry?
110 beats per minute.
Okay.
Right, so no obvious IT regurgitation. So this is a short axis view of the aortic valve. Normally, very, very difficult sometimes in a calcified valve to determine the number of leaflets. If the patient have aortic stenosis, however, and they are relatively young, most of the time it is because of bicuspid aortic valve. Bicuspid aortic valve is actually the commonest congenital heart disease, even more common than atrial septal defect. And the most common reason patients that have aortic stenosis undergo aortic valve replacement is actually not degenerative trileaflet aortic valve, but bicuspid aortic valve. Nevertheless, we are unable to determine the number of leaflets in this transthoracic echocardiogram of this patient. So this is a apical 5-chamber view, LA, LV, RV, and aorta. You can see clearly here that the valve is stenotic. You can see calcified and very restricted opening. Again, there is no aortic regurgitation seen here. Again, in apical long axis view, no aortic regurgitation and calcified aortic valve. So the way for us to do assess aortic valve severity is by looking at the velocity across the aortic valve. A velocity of more than 4 meters per second usually denotes severe aortic stenosis. A mean gradient that is more than 40 millimeter mercury and the aortic valve area that is less than 1 centimeter square is what we call a straightforward high gradient severe aortic stenosis. Mean gradient more than 40 and aortic valve area that is less than 1. Many times, however, we do see an entity called area gradient mismatch, in which the gradient is less than 40 millimeter mercury, but the area is also less than 1 centimeter square. There are many reasons for this, namely either the patient can have low flow across the aortic valve causing low gradient, even though the aortic valve stenosis is severe. So we have a few entities: classical low flow, low gradient severe aortic stenosis, paradoxical low flow, low gradient severe aortic stenosis, and also normal flow, low gradient severe aortic stenosis. So this is very common, and the way to go approach these 3 different entities is different, and you have to be knowledgeable about that. I say that because in this case, the entity is rarer. When we use a continuity equation, so continuity equation is based on the principle that whatever go into the aortic valve, into the LVOT, is the same that go out through the aortic valve. So therefore, we can calculate the aortic valve area in this case of 1.21 centimeter square. So the aortic valve area is not severe; it's more than 1. But when we look at the continuous wave Doppler across the aortic valve, we see a mean gradient that is more than 40, which is 67.8 millimeter mercury. So this is rarer. So we have area gradient mismatch, in which the gradient is low and the aortic valve area is low. We also have an entity called reverse area gradient mismatch, in which the aortic valve area is more than 1, but yet the mean gradient is more than 40 millimeter mercury. Why is this so? The most common cause is because of high flow state. Normally, a concomitant
Hello?
is someone with big body surface area, someone with high flow because of hyperthyroidism, or someone with an unused AV fistula. So does this patient have a concomitant high flow? When we look at the color, we see obviously the patient does not have concomitant severe aortic dissection. So that is not the explanation. The patient is also not hyperthyroid and the body size is normal. So why this reverse area gradient mismatch? So from transthoracic echocardiogram, we actually proceed to transesophageal echocardiogram. And finally, in transesophageal echocardiogram, we can see clearly that this is a bicuspid aortic valve. You can see a non-coronary cast here, and you can see a fused right and left coronary cast with a raphe connecting these two leaflets. This is the most common type of bicuspid aortic valve. We call it a Sieverts 1 right and left fusion. A tips on determining the number of leaflet is to look at the opening during systole. If the opening is triangular, so it is trileaflet. If the opening is oval, it is more likely to be bicuspid. So the patient have bicuspid aortic valve. So a less well-known fact is one of the main reason of reverse area mismatch is bicuspid aortic valve. Why? Because in bicuspid aortic valve, when you have aortic stenosis, sometimes the turbulent flow rather than central is eccentric. And this eccentricity actually hit the aortic wall very near the aortic root. And the eccentricity causes higher gradient for a given aortic valve area. So, for example, in a normal aortic stenosis with a central jet, an aortic valve area of less than 1 millimeter mercury, less than 1 centimeter squared, gives a mean gradient that is 40 more than 40 millimeter mercury. But in bicuspid valve with eccentric jet, a big aortic valve of 1.2 can already give a higher gradient than 40 millimeter mercury. So this is the apical long axis view, and on the deep transgastric view. So this is an interesting view that can be difficult for someone who just learned to do transesophageal echocardiogram. So this view is important to assess the Doppler of the aortic view in the transesophageal echo, where you can get a parallel direction between the flow of the stenotic jet and also your ultrasound probe. This is basically the main image that I wanted to show. You can see that the jet actually go eccentric and hitting the aortic valve. That is why you have the reverse area gradient mismatch. So we finally get the answer for this patient. This patient have a fusion of right and left coronary cast with bicuspid valve. There is no aortic regurgitation. In this case, even though the area is more than 1 centimeter squared, the mean gradient is more than 40 because of bicuspid valve and the eccentric jet, as illustrated on the last image. So in summary, bicuspid valve with eccentric stenotic jet is one of the commonest cause of reverse area gradient mismatch. And I think this entity need to be learned. People need to be aware about this entity because sometimes this will come to your echo lab.
Okay, now wait, go back to that case because I got a question. I want to ask you, in this case, do we take it as severe then? Do we take the gradient or do we take the area?
So in this case, we take the area rather than the gradient.
Okay, so
Because we do study, me and my colleague in IJN do study. And in this study, we noticed that those with reverse area gradient mismatch, even if they undergo operation, the outcome is the best out of all the others. Meaning that it's more likely that this doesn't represent a true severe rather this is a moderate aortic stenosis.
okay. Now the second question I want to ask is, why is it that bicuspid valve are so prone to degeneration compared to a tricuspid valve?
This is because of the mechanism of the flow. They do a 4D cardiac MRI flow analysis, and it's just the physics is rather complicated. but the flow through bicuspid valve is not as efficient as the flow through a trileaflet aortic valve. Because of this inefficient flow, there's a lot of friction in the opening of the valve, causing calcification and degeneration of bicuspid valve to occur more frequently than trileaflet aortic valve. Second reason is that genetically, the bicuspid valve has a easier formation of osteoblast. The osteoblast is basically akin to bone formation, and this can also cause rapid calcification of the valve.
Oh, that's interesting. Okay, next case.
All right, let's go to the next case. So this is a case of 51 years old female. You can see at the parasternal long axis view, we can see a borderline ejection fraction of 46.2%. We can see a calcified aortic valve.
Doctor, can I ask one more question?
Yes.
If the patient has a, let's say, a gradient over the LVOT,
Yes.
will it make a difference to our calculation of the aortic stenosis
Yes.
gradient?
Yes, and this become very, very complicated when you have a gradient in series. So if you have a gradient in the LVOT and you have gradient in the aortic valve, there is really no way for you to separate these two gradients. So in this situation, usually I didn't do continuity equation.
Sorry, you are lagging. Am I
So-
lagging?
Can you hear me?
Okay, I can hear you now.
All right. So whenever you have obstruction in series, in which you have a obstruction in the LVOT and the obstruction in the aortic valve, it is very difficult to do a continuity equation and to calculate the aortic valve area in this case. So in this situation, normally I will do planimetry to calculate the aortic valve, to look at the aortic valve area rather than using a continuity equation.
I see. Okay, thank you.
Right, this is another case where you can also see a thickened left ventricular wall. We can see a calcified aortic valve and a thickened mitral valve. You can see here turbulent flow across the aortic valve. So the patient have some aortic stenosis and also severe aortic regurgitation and also mild mitral regurgitation. So we have a zoom view of the aorta. We get the LVOT with a radius of 1.15 centimeter. We need the radius because that radius is important to calculate the aortic valve area via continuity equation. So basically here it's best to illustrate the principle is whatever going into the aortic valve through the LVOT is the same as the one that go out the aortic valve. So pi r squared times the LVOT VTI is equal to AV VTI times the effective orifice area. So you just rearrange the equation and you get your aortic valve area. Don't worry, continuity equation is valid even in the presence of concomitant aortic regurgitation. Now, when you look at the short axis view, we can see that, again, as we see with the previous case, I am unable to determine the number of aortic valve leaflet here because of the heavy calcification.
But it looks tricuspid to me.
Okay, so it looks tricuspid to you.
Yes.
So I agree with you. I think if you want me, you put a gun on my head and you want me to get, I will say that this is a trileaflet aortic valve as well. But the patient is relatively young. I think she's I think 50. So very unlikely for a trileaflet aortic valve to degenerate as early as this. So this is an apical long axis view. Again, you can see that the significant aortic regurgitation with mild mitral regurgitation. We look at the Doppler here. Again, here we can see that the aortic valve area from continuity equation is 1.1 centimeter squared, yet the mean gradient is more than 40 millimeter mercury. We have the same situation as we see in the previous case, where we have a reverse area gradient mismatch, in which the mean gradient is more than 40, even though the aortic valve area is more than 1. Why in this case this is so? In this case, we have a ready explanation because the patient have concomitant severe aortic regurgitation. So therefore, the patient have high flow across the aortic valve and reverse area gradient mismatch. It is also possible that this patient also have a concomitant bicuspid aortic valve. But as you can see from the short axis view, this might be unlikely because the shape look like this is a trileaflet aortic valve. So this is a descending aorta. So this is very important in the assessment of aortic regurgitation. because you want to see a backward flow in the descending aorta. So this is what we call a diastolic flow reversal. Usually in normal people without regurgitation, either there are no flow backward or there's very little flow in the beginning. But in patient with severe regurgitation, you can see a reversal of flow throughout the whole of diastole, like in this case here. Even more strikingly and more specific, if you can have reversal of flow in the abdominal aorta, this is much more specific. Basically, you can bring it to the bank that the patient has severe aortic regurgitation. And as you can see here, the forward flow across abdominal aorta, and this is the backward flow across abdominal aorta, which is the hollow diastolic flow reversal in the abdominal aorta, suggesting indeed that this is a very severe aortic regurgitation. So what is my thought about this case? So this is a relatively young 51 years old man with severe aortic regurgitation, taking LVOT 1.15 centimeters, aortic valve VTI of 120 centimeters, and peak velocity of more than 4 and mean gradient of. We got a reverse area gradient mismatch with AVA of 1.1 and mean gradient of 51. So this is the reverse area gradient mismatch aortic stenosis that is easily explained due to concomitant high flow of severe aortic regurgitation. There is a slight reduction in ejection fraction of 46.2% and mild to moderate functional MR. Now, because I am still unsure on the number of leaflet, I proceed with transesophageal echocardiogram. So this is a mid-esophageal long axis view. So you can see that the one of the leaflet is calcified and the other one is restrictive. And you can see significant aortic regurgitation. We measure the vena contracta, which is the neck of the aortic valve regurgitation, and that is more than 6 millimeter. So this is indeed severe aortic regurgitation, right? However, we have a surprise when we look at the short axis view, AOPA view of the aortic valve. Okay, this is actually not a trileaflet aortic valve. Rather, this is a unicuspid aortic valve, i.e., aortic valve with a single leaflet.
Oh.
Yes. Because what happened here is that you have a fusion of this leaflet.
Hold on, we are
fused with this leaflet and fused with that leaflet. Okay, all these three leaflets.
Are you lagging? Or am I lagging?
Nice here, but I'm not sure whether it's lagging. Are you okay now?
We are okay now.
Okay, so these three leaflets here actually connected to each other. Okay, these are connected to each other by a referee there and there. This is the only opening. So this is a unicuspid aortic valve. And this unicuspid aortic valve actually causes a concomitant severe aortic stenosis and a reverse area gradient mismatch aortic regurgitation. In this situation, I don't think unicuspid valve actually contribute to the reverse area gradient mismatch. I think that is because of concomitant severe aortic regurgitation. Nonetheless, it is interesting because this is the commonest type of unicuspid valve. The other type of unicuspid valve is very rare, in which you have a pure unicuspid valve, which you truly have a single leaflet without any fusion of the leaflet. So my final thought on this case, so the key TEE clears the diagnosis of functional unicuspid valve, where all the valves are connected by referee. The aortic stenosis jet is relatively central, and therefore the most likely cause of reverse area gradient mismatch is the concomitant severe aortic regurgitation. And the patient successfully underwent aortic valve replacement. So
for example, if you have not done the TE and then you are so confident like me, you would think it's a tricuspid valve, you may make a diagnosis of, let's say, chronic rheumatic heart disease. Okay, I mean the end management, of course, the final management is still the same.
Right.
It's very interesting. I never heard of unicuspid valve, to be honest.
Yes, we have unicuspid, bicuspid, trileaflet, and quadricuspid. I've never seen 5 leaflet. I don't know what to call it. What do we call quadricuspid? 5 leaflet. I'm not sure. So I think, Dr. Betty, we have 5 cases. Shall we stop here?
I think so. We can stop here. So there are some questions. I think let's take some questions. Where is it? Just now, this one. Okay, from Zoom, yeah. The attendance has been great. Dr. Johan asked, How has the role of echocardiography evolved in recent years as a diagnostic tool? And what are some of the key advancements that have improved in the diagnostic capability? Oh,
So I think it has advanced by leaps and bounds since the era of, I think they start with the B mode. In B mode echocardiogram, you only see a point, just point here, point there. And then after that, you got M mode. In M mode is a 1D images where you can see the movement, but not really a 2D image. Then after that, you got 2D. So we are all familiar with 2D. This is what we do day in and day out in all the lab. After that, we have 3D, and 3D now has really come into prime time, especially in transesophageal echocardiogram. As I show you in my cases, we can see almost exactly the same thing what the surgeon can see when they open the heart. In fact, we can actually pinpoint within a millimeter where exactly is the pathology. So we can see the ruptured cord, we can determine where is the scallop, we can tell whether the patient have abscess, pseudoaneurysm, fistula. In fact, if you talk about transthoracic echocardiogram 3D, we can actually use 3D to calculate ejection fraction, which much greater accuracy than 2D echocardiography. We also have now something that is called speckle tracking imaging, in which we can track the speckle, which is a white dots that is reflected by the heart muscle, and look at the function of the heart muscle with more specificity and sensitivity, so that we can diagnose this function earlier. So for example, ejection fraction of 55% might seem normal, but if you use speckle tracking and you get a lower value than normal, for example, negative 15%, you actually have a subclinical LV dysfunction. So you have 3D echocardiogram and you have strain speckle tracking. And finally, now, of course, is the area of artificial intelligence. So a lot of people have incorporated artificial intelligence into the echocardiogram. To give you an example, nowadays, in order to determine the true severity of aortic stenosis, we might need to do a CT calcium score. We might need to do a low-dose lobotomy stress echocardiogram. But with artificial intelligence, by virtue of storing hundreds of thousands of a pattern of aortic valve calcification, rather than needing to do all these tests, the computer can just look at the degree of calcification, and from then onwards determine the true degree of severity of aortic stenosis.
Okay. For example, all this capability to assess the pathology to the very spot, does it help the surgeon?
Oh yes, it helped them a lot. It helped them to anticipate what operation to do. For example, whether it is repair or replacement. It made them anticipate the complication that can go after operation. For example, if they were to put the valve, will this valve develop, if they were to repair a valve, will this valve develop systolic anterior-motion of the mitral valve post-operation? For example, if someone wants to put a mechanical valve in the mitral valve, will this cause obstruction of the left ventricular outflow tract? All of this answer can be answered by 3D echocardiogram. So it is extremely, extremely useful.
Okay. Dr. Susie asked, could you elaborate the role of electrocardiography in the early detection and monitoring of heart disease, especially with patients with risk factor or genetic predisposition?
So definitely, like I said, before this, you use ejection fraction to detect left ventricular dysfunction. I give an example. If you are thinking about chemotherapy-induced cardiomyopathy, you actually can use echocardiogram to monitor the chemotoxicity to the heart. So one thing you can do is that you can do echocardiogram every 3 months and see whether there's any reduction in the ejection fraction. If there's any reduction in ejection fraction, you can actually start to institute anti-failure therapy or try to modify the chemotherapy regime. But by just looking into ejection fraction, it might not be sufficient, because when the ejection fraction comes down, it might be too late to intervene already. So nowadays, we use speckle tracking. Rather than waiting for the ejection fraction to come down, we look whether the speckle tracking value come down before the ejection fraction, so we can actually intervene earlier. Another example is people with bicuspid aortic valve. Again, we can do echocardiogram early, and we can look at the bicuspid aortic valve, see the pattern of calcification, and maybe predict by using artificial intelligence how fast this bicuspid valve will progress. We also can use echocardiogram to look at the flow across the aortic valve and to see whether this flow have any relationship with the progression. So that's just a many different example of how we can follow the progression of heart disease. But there are many others. These two questions that were asked deal with generalities, and I do felt that this is an exciting field for a budding cardiologist, rather than always just interested in, for example, angiogram and angioplasty.
Okay, Dr. Sunita, okay, Dr. Christina spoke about pentacuspid.
Pentacuspid, okay, so that is the 5. Wow, I think she's answering my
Oh,
question.
I see, okay. So Dr. Sunita asked, what's the percentage of EF that is considered normal?
Okay, using
yeah.
using guideline now, if you use guideline now, for female is more than 54%, for male is more than 52%. That is guideline now, 54, 52. However, after the WAVE study is the study, because these all numbers that we are using now is actually derived from mainly Caucasian and Black population in a Western country, not Asian country. And many of these numbers also were derived from a not good quality echocardiogram with a lot of foreshortening and no standardization. So now I think in the near future, maybe in 1 year or in months time, the percentage will change, i.e. for male more than 57% and for female more than 58%.
Okay, so Dr. Kumarasamy said, okay, thank you for the excellent talk. But he want to ask you, when do you recommend a patient for dobutamine stress test? Oh, I think
So,
that. Okay.
you want me to answer that?
Yeah, sure.
I mean, I think this is not something not to do with echocardiogram. So if you
Yes.
want to do dobutamine stress test, so basically stress test is just, you want to stress the heart and you want to see whether there's any ischemia. So normally the best thing is of course to do treadmill stress test because you can also assess the patient physical capability and stamina. But sometimes the patient cannot run or cannot cycle because of physical limitation. So in this situation, we do recommend dobutamine stress test for a normal ischemic test. However, we can also use dobutamine to do a stress echocardiogram. So we can do a dobutamine stress echocardiogram to assess something that is called viability. Whenever we see a regional wall motion abnormality and we want to see whether that region is infarcted, hibernating, stunned, or done ischemic cardiomyopathy, you can do dobutamine stress echocardiogram. In a patient with classical low flow, low gradient severe aortic stenosis, you can do low dose dobutamine stress echocardiogram to determine whether this is a true severe aortic stenosis or pseudo severe aortic stenosis.
Okay, I think we will stop here. And of course, we will continue the series next year. I'm already spoken to Aslanif. He has agreed. So we will probably do 3 or 4 again next year because there's so much to learn. Just so much. I mean, I've been practicing cardiology for 30 years, but every time I learn new things when I listen to your talk. Okay, Christina Saw said, actually, can echo be a non-invasive test for coronary artery blockages? Yes, you can do stress echo. It is not, it's non-invasive, it's objective. It's not something that I really enjoy doing, especially with this, I mean, with CT angio being so readily available, I think stress echo is hardly used these days. What do you think?
Yeah, I think so. I think so too. If you do stress echocardiogram, I think it's very useful. I like to do stress echocardiogram. Very accurate if let's say it's read by a very expert person.
Yes.
So if the stress echo is read by me, it is 100% accurate.
Yeah, I hardly do at all. Because you really need an eye to see the
Hypokinetic region.
yeah, hypokinetic, and it's quite difficult for me.
Yeah, it is difficult. Yes.
I don't do enough. Okay, thank you very much.
Thank you,
you.
for your invitation.
Thanks, it was so good, I was
Thank you.
wait, hold on,